complaining about her heels, and then there we
Wow,
are.
you should wear some not comfortable.
All right. CEA we talked about yesterday is a way to measure resurgence of cancer after the treatment, primarily. It can also be measured at the diagnosis, the time of diagnosis. As a matter of fact, I would do that. If you have a cancer diagnosis, I would get a CEA level. If it's 0 today, or if it's 1,000 today, that gives you a benchmark to go on. As you, what?
Sorry, what you said, benchmark.
What did you say?
Benchmark.
Benchmark. Yeah. Benchmark.
How about baseline?
I'm from Alabama, so sweat chloride, the pathognomonic thing about sweat chloride, if I say 60, you say cystic fibrosis. Sweat chloride, we talked about this when we dealt with fluid movement. Pilocarpine is, so you know that the sweat glands are innervated by postganglionic sympathetics.
Yes.
And the neurotransmitter there is not, well, the neurotransmitter here is acetylcholine. So pilocarpine is an analog and will stimulate the production of sweat. They measure, there's a little patch that's put on the skin, a low voltage current is run through that patch that produces sweat. The sweat's collected in a pipette and analyzed. The mark is 60. If your chloride level is above 60 millimoles, that's CF. No way around it. So, and it can be done in little kids. It's not painful, and you send them to the lab to do it. And they usually batch it, so you can't, send them right over there to do it on Tuesday afternoon or Wednesday afternoon. They would only do it like on the 3rd Thursday of the month. So you'll have to check with the lab about when they can do it. But if it's positive, so give me an indication of why you would do it. Why you would do it. I've got a 2-month-old here. Why would I do it?
Failure to thrive.
What?
Failure to thrive.
Failure to thrive, because I've told you this before. Failure to thrive. What constitutes failure to thrive? All of those things, yeah, very good. Frequent infections. Frequent infections, poor weight gain, probably two big ones. Well, also, the stool itself is a big thing. The stool itself.
When their moms kiss them, they taste salty.
When the moms kiss them, they taste salty. It's like, yeah, I've had a lot of CF patients. I've never licked them. But, the next CF patient I have, I might try that.
Finish listening to their heart.
General categories here. Now we're going to focus on some liver diseases here. Diseases of the hepatocytes themselves and the cholestatic side, the diseases of the tree. The first slide here lists the various presenting symptoms, from nothing to everything. And when I say from nothing, I'm talking about somebody walking in and complaining of something innocuous, and you wind up getting okay, that could be a duck stone. You get an ultrasound, and they wind up with some 8-centimeter primary hepatocellular carcinoma so that they didn't even know about. So they can present asymptomatic. You can have a lot of things like jaundice and pruritus that are associated with bilirubin. We're going to talk about bilirubin pathway here in just a second. Bruising and bleeding have a lot to do with what?
The cascade, the vitamin K.
Right, vitamin K dependent clotting factors are liver derived. There you go. Cholestatic disease, it's the same thing. It's the same thing. Pruritus, because when bilirubin builds up in your blood, in your skin, actually, you not only turn yellow, jaundice, it causes, it's very pruritic. You itch, and boy, do they itch. And there's really not much you could do about it. The clay-colored stool we talked about yesterday, being North Carolina, New England, not Oklahoma, Texas. Okay. All right. Physical signs, you see them here. On this side over here, these are more late signs. They're not more late signs, they are late signs because they involve structural changes in your anatomy. I'll show you a picture of each of these here in just a second. Well, this is clubbing. This dude on the right looks like a freaking gecko. I'm pretty sure he can climb the glass wall. I've never seen clubbing anywhere nearly that bad. But to this extent down here, you will see this a lot, not only in hepatic diseases, but obviously emphysema, even asthma that's not controlled. Jaundice is pretty easy to recognize. In fluorescent lights will make it a little bit more difficult. You need to get them into direct sunlight to really appreciate how yellow a person can be. You go to Penn Square Mall, have a seat, and about 30 minutes later, you're going to see, within 30 minutes, you're going to see somebody jaundice come strolling by. Jaundice describes the skin, the yellowing of the iris, of the sclera is the what? Is what? Icterus, very good, yeah, icterus. So it can be pretty impressive. Somebody with hepatitis A, which, they went out to the restaurant, they ate a bunch of oysters, they wind up with hepatitis A. They get yellow like this, they have some tenderness, and it's a self-limiting disease. Within a few weeks, they're back to normal, and all is well, other than the fact that they probably contaminated their whole family. But it can look bad and not be bad. But if this is occurring, this looks bad and it is bad. This is just a ton of ascites as a result of cirrhosis and or liver. This right here kind of looks like the liver edge. That may be the liver edge there. I don't know, but I've seen some humongous livers all the way down into the pelvis, and I'm sure in GI, in the emergency room, you've seen them also. When you start trying to find that liver edge on the abdominal exam, next thing you know, you're down around the patella. It's just, well, you're not that far down, but you can't get past the inguinal ligament. But you start.
Interventional radiology too, because we do a lot of the paracentesis to pull that off. And
Yeah.
So
The problem.
Doing all day long.
Yeah, the problem with it is, like, if this guy has 10 liters right here, you can't pull all 10 liters off at one time. They'll do fluid shifts and they'll crump on you. So you have to pull a little off, you wait a while, pull a little off, and it's a long process. So. Spider angiomata, I mentioned this yesterday relative to something else, I don't even remember what now, but the head, the body of the spider is the arteriole. The capillaries are what are going out from it. Those are the spider legs. And these things are dilated, and these are quite common. It's associated, of course, with fluid dynamics and the clotting mechanism. As distinct from spider nevi, this is not related to cirrhosis or ascites, but I put it in here because it's a clinical manifestation. You may have spider nevi. You will not have spider angiomata, I can tell you that. Okay? Paul might. All right. Palmar erythema, these are, this is the way these people, they look, they're hyperemic, they're red. Kristen, you don't have, no, you don't have it, no. So, it's a manifestation, it's a late manifestation in the end. And of course, you guys remember from anatomy what a diseased liver looks like versus a normal liver looks like. It's pretty remarkable. The thing that's going to impress you most is the size on some of these patients and how actually large it can get. This is not a good situation. This is a very jaundiced individual. He's got ascites. If you did a fluid wave on his abdomen, meaning if you put your hand right here and pushed on this side like that, you would feel the succussion splash on the other side. So, so I was with somebody and Paul and he had it. I didn't have it. Yeah. So it's not. You do not have. There's no way is your skin of the last related to this. Okay, so don't even be sitting over there poking on yourself. We all know about portal hypertension. I told you about this in beginning in anatomy, that anytime you have a cirrhotic liver, the portal valves, remember the portal veins have no valves. So the direction of blood flow can be in either direction, and it's going to affect these different systems. When you start looking at the anatomy, remember the esophageal varices up here, or is the junction between the portal system and the cable system. Also, what are the two other problems primarily? Hemorrhoids down here, the superior rectal vein and arteries, and the caput medusa around the caput medusa around the umbilicus. Remember that, okay? All right, so you have a liver dysfunction. What's the prognosis like? So, like the Ransom criteria, there's a Child-Pugh formulation to look at the severity of liver disease and the eligibility of putting somebody on a liver transplant list. And so this was used for that. You guys still use? Yeah, still use?
You can Google up the calculators, plug all your numbers in.
Yeah. And you see that it's focused on things we've already talked about. The PT, which we know is related to vitamin K dependent clotting factors. Albumin, I told you before when we talked about fluids, the hydrostatic versus the oncotic influences of blood. Albumin is your major determinant there. Bilirubin, we'll talk about here in just a second, is an estimation of liver function. Liver enzymes that we'll talk about do not describe liver function. Bilirubin does. You need to keep that in mind. The presence of ascites and hepatic encephalopathy is, we'll talk about hepatic encephalopathy more when we get to neuroanatomy. There's one in particular, well, we'll just save it to then. There are different levels of survivability here. Some are good, some are not good. 2-year survival in a class C is you're looking at, well, a third of these folks will be around 2 years later. So it's not good. Things to know. All right, so let's talk about bilirubin. So we start with hemoglobin. Hemoglobin, remember, has two components, heme and globin. Globin is a protein made up of amino acids. Your body conserves amino acids, nitrogen, because of the nitrogen. You're going to reprocess the globin into your other amino acids and proteins to use in your body. The heme component, though, we got to get rid of. And the way you do that is you convert it initially, you bind it with albumin. The spleen does it, specifically macrophages in the spleen will combine heme with albumin. Where does the splenic blood, where does blood from the splenic vein go? It goes to the liver. One of the three things that form the portal vein, right? Goes to the liver. So, heme bound to albumin coming from the spleen is called indirect or unconjugated bilirubin. I like to use the terms conjugated and unconjugated, although they're really a misnomer because it's bound to albumin. It's already conjugated, but that's not the way you use the term. It's unconjugated if it's with albumin. Now, if it's with albumin, you ought to know right now it's not going to make it through a glomerulus normally, right? You're not going to be able to pee albumin-bound heme or unconjugated bilirubin. Once it gets to the liver removes the albumin and binds two glucuronide molecules to it. It now makes it water soluble. This is called conjugated bilirubin or direct bilirubin. Most of it is secreted through the bile duct system into the small bowel. Some of it will remain in your circulation. Some of the unconjugated will make it through the liver without being acted upon, so you'll have a small amount of unconjugated in the circulation as well. The way you look at it is your total bilirubin is conjugated and unconjugated. The value of total bilirubin in a normal person is 1 milligram per deciliter, something like that. 1 milligram per deciliter. And it's a 1-to-1 relationship of conjugated and unconjugated. So 0.5 and 0.5 unconjugated and conjugated make up your total bilirubin. That's what you have in your body right now. So I would draw your blood, you would have no more than 0.5 of each one of those, and your total bilirubin will be less than 1. Normal. Now, let me say that, let's go back to the bile duct system. That conjugated bilirubin is, well, let me say one more thing. When it's conjugated to the diglucuronide molecule, I said it makes it water soluble. If it's water soluble, you can pee it out, right? So if I were to pee a cup right now, and I said that there was some normal level of conjugated bilirubin in my blood, then I would expect to find a little bit of conjugated bilirubin in my urine. What I won't find in my urine is unconjugated because the albumin prevented me from peeing. It was only the conjugated that I can pee. Now most of the time, the level is going to be so low, the value in urine is going to be 0. But if you ever have anything that's going to screw with bilirubin, and you wind up with excess conjugated bilirubin, understand that it can wind up in your urine. It will wind up in your urine. Okay? Can we say that again?
It looks like iced tea.
Yeah, well, that's not just all correct.
Oh.
If I do something that screws up bilirubin metabolism, and I wind up having excess conjugated bilirubin, then when I pee, the conjugated bilirubin, the bilirubin level in my urine will go up. Now, I'll give you a quick example. if I put a duct stone right there in my bile duct that blocks bilirubin from entering, which is where most of it goes, 99% of it goes into the GI tract. But if I block it there, it's got to go somewhere. The liver's still conjugating it. You got to get rid of it. Where's it going to go? It's going to spill into the circulation, right? So I pee in a cup, you would expect to find an increased bilirubin. If I were to draw my blood, I would have an increased conjugated bilirubin. What do you think would happen to unconjugated bilirubin? Nothing. It stays the same. You're still processing hemoglobin at the same rate. That hasn't changed. The only thing that's changed is when you got over here and conjugated it, you couldn't eliminate it, you put it in the serum. So if I have a duct stone here, instead of my total bilirubin being 1, it might be 4. And if you break it down, the conjugated is going to be 3.5, and the unconjugated will remain 0.5. If you can get that simple concept down, you're going to be so far ahead of most providers who can't figure this out to save their ass. What do you think would have to happen to increase the amount of unconjugated? What? Yeah, a hemolytic type of anemia, where you're presenting more hemoglobin to the spleen. What do you think's going to happen? Well, I can't really say that. I was going to say, what do you think's going to happen when it got to the liver? Well, you're still conjugating at the normal rate. So if you had a total bilirubin of 4, theoretically 3.5% of it this time would be unconjugated, 0.5 would be conjugated. But it doesn't really work like that, because if you present more unconjugated to the liver, it can ramp up the conjugation. Okay, so, but that's the, you got the idea, right? Okay. So we got bilirubin going into the GI tract. Conjugated bilirubin is spilling into the GI tract, small bowel, at the ampulla of bladder. It's acted on by bacteria. It's converted to urobilinogens. Let me skip ahead to this little schematic here. So you've got the bilirubin entering here. It's acted on by bacteria to form urobilinogen. Now, some of that urobilinogen is absorbed in the intestines and enters the circulation right here. So in the circulation, you have conjugated bilirubin, unconjugated bilirubin, and urobilinogens. Urobilinogen is water soluble, so you can pee it out. Normally, there's a little bit of urobilinogens in your urine. That's what makes it yellow. It oxidizes as soon as it hits the air and turns the pee yellow. Urobilinogen is further acted on and converted to stercobilinogen, eventually stercobilin, and that's what gives your poop the characteristic, lovely brown coloration. So it's the bilirubin that makes your pee yellow and your poop brown. Now, if we put a stone right there, or a cancer in the head of the pancreas right there, understand some things are going to happen here. One is, we've already said, you're going to have an increase in your blood conjugated bilirubin, right? The second thing that's going to happen is You're not getting any bilirubin into the GI tract, so you're not going to have any stercobilins, which means your poop is going to be tan colored and not brown. You're also not going to absorb any urobilinogens, so that in your urine you will have 0 urobilinogens, but excess conjugated bilirubin. Right? If you ever see a dipstick urine, and we'll talk about dipstick urines, because the dipstick urine has a different test, right? A different test. One of them is bilirubin, one of them is urobilinogens. Normally you have 0 bilirubins, and the normal level of urobilinogens on a dipstick is like less than 0.02, and I can't remember what the units are. So normally you have a little bit of urobilinogens in your urine. If you obstruct that right there, that will be 0. So if you ever get a dipstick back and the bilirubin is 4+, and the urobilinogens is 0, you have something going on right there. If you're yellow and you're not in pain, number 1 on the differential is what? Pancreatic cancer. If you are in excruciating pain, it worsens when you go over there and get a bucket of fried chicken, it's stone. That's the picture you're going to see. Any questions about that? Okay. This right here, as you read through this, explains everything we just said. Then you have a question.
Oh, I was just going to ask earlier, if the labs, so like you said, total bilirubin, for example, before, would that be the only reason if there would be a stone blocking for the conjugated to be higher? I don't remember where it was.
So the question is, can you get an elevated conjugated bilirubin by things other than stone? Yes, you can. Tumor will do it, and those are the 2 biggest.
So it's something obstructing it getting into
Most of the time. Most of the time. Again, I said that if you increase the amount of unconjugated presented to the liver, you could increase the conjugation rate. Where you won't get an increase in conjugated bilirubin is in things like hepatitis. There, the conjugation will either be sometimes normal, most of the time low. So if you're not conjugating, what do you think's happening? Why do you turn yellow? Why do you have hyperbilirubinemia in hepatitis? What is elevated? Is it conjugated? No, it's unconjugated because you're producing all this unconjugated bilirubin and your liver can't process it. So that's what's turning you yellow, is unconjugated bilirubin. And you can't get rid of it because you can't pee out unconjugated bilirubin because it's attached to this 64,000 kilodalton protein. I think it's impressive that I know that albumin weighs 64,000. So anyway, you might not. I mean, I may have just made that number up. But it came to my, somebody Google that. Am I right on that? What's the molecular weight of albumin? I'm probably not even in the ballpark.
66.5 kilodalton.
How much?
66.5 thousand.
66, I was 2,000 off. Boom! All right, let's go back to some of this other stuff. All right, so this is what I was saying on a urine dipstick. On a urine dipstick, you have, it'll say bilirubin, but understand, it's conjugated bilirubin. If you have, in the case of hepatitis, if Bethany is yellow as a gourd, her total bilirubin is 8. her total bilirubin is 8. She has hepatitis B because she's an IV drug user, and we know about the other stuff she does. Okay? All right, she's got hepatitis B out the yin-yang. If her bilirubin is 8, what's her unconjugated bilirubin? It's not 4. What do you think her conjugated bilirubin is going to be? It's going to be 0.5 or less. Because her liver doesn't work. So if her total bilirubin is 8, her unconjugated is going to be around 7.5. 7.5. What is this going to show on the dipstick right here? Not one drop of that 7.5 will show up on that dipstick because it's attached to albumin. You can't pee it out.
So, can you pee out unconjugated bilirubin if like there's renal disease involved?
Yeah, so if you've got glomerulonephritis or nephrotic syndrome or nephritic syndrome, yes, you're going to be peeing proteins. But ordinarily, if you've got an intact glomerulus, it's not going to make it through. Okay? There's another thing here, is that you should recognize that in your hepatitis B infected state, the urobilinogen is going to stay about normal. Because where do the urobilinogens come? They come from the conjugated, which is at a normal or low value, right? Does this make sense? Okay, so when you come down here and look at these things right here, hemolysis, hepatocellular disease, as far as an increased urobilinogen, why do they say antibiotic use will decrease urobilinogens? Why is that? Why would you have decreased urobilinogens with antibiotic use? I'll put you on amoxicillin for your ear infection. Maybe I always stop picking on Bethany here. Why is antibiotic use associated with a decreased urobilinogens?
Bacteria.
How do you get urobilinogens? They have to be converted from the gut bacteria. We've already talked about C. diff, and when you take an antibiotic, you destroy the bacteria in your colon, in your vagina. Why do you get yeast infections when you're on amoxicillin for your sinusitis? It's because you destroyed the normal bacterial populations. You changed the internal milieu of the vagina or the GI tract, and in this case, it's going to affect urobilinogens. In the case of the other woman there, she winds up with a yeast infection. And people think I'm nuts. But if I saw you over in the student clinic, I would just ask you, by the way, when you take antibiotics, do you have a problem with yeast infections? If you say yes, you're going to get a diflucan, a script for it, as you walk out the door. Because I don't need you calling me a week later with a raging yeast infection. And I would encourage you to do the same thing. It's not the standard of care to do that. It's just freaking being nice. All right, any questions about any of this? So I can promise you that on this test that Professor Rourke is going to give you, there will be something where you're going to have to use your reasoning skills to figure out where the problem arises regarding circulation of bilirubin. Okay? Now, on a CMP, those who ordered a CMP today, you don't get all three. You don't get total, unconjugated, conjugated. You're only going to get total in one of them. All you do is subtract that from the total, and that will give you the other. They don't bother giving you all three. Okay? Cases of hemolytic jaundice, in terms of why. Sickle cell anemia is a big one. That's probably, in the world of hematology, it's probably the #1 cause of hemolytic jaundice, I would say. Idiopathic hemolytic anemia is probably a distant second. Excessive erythropoiesis, give me a couple of diseases where you see that. I think I might have mentioned them to you before. Hemochromatosis is one of them. Hemochromatosis is one of them when you have an increase in hemoglobin mass. Professor Rourke? Polycythemia vera. That's another, those are the two probably most common. Okay. Absorption from hematomas. You know, it's the weirdest thing. You get, this is the funniest thing. I'm working up in the Blackwell ER. This is back before Professor Reggio was in PA school. And there was an OBGYN. He was headed up, he was on his Harley, headed up to South Dakota for Sturgis, right? To meet his girlfriend up there. And he laid his bike down on I-35 right there beside, and they always brought him over to the Blackwell ER. So about 10 o'clock at night, he shows up. He's in his leathers, but he's just, the road rash was impressive. I mean, he didn't have a bit of skin left on him. He was perfectly awake, in a lot of pain, but as I was attending to him there, and he reached into his pocket and he pulled out a wad of $100 bills. I mean, it was a big old wad of $100 bills. He said, "Would you put this in a safe or somewhere in the hospital?" Sure, we'll take care of that for you. He said, "Then, would you call my wife in Austin and tell her that I've had an accident?"
Nice.
Okay, what would you like for me to say to her? That you were going to Sturgis to meet your girlfriend? You might want to leave that part out. True to form. The reason I'm telling you this story, which is a true story, his wife did come up. This was on a Friday night. She came up Saturday. I admitted him, and she came up Saturday. She's a very nice woman. Being cheated on like crazy, but very nice woman. When you're looking at his complete metabolic profile, I start seeing changes in bilirubin. Well, why? He had road rash everywhere. So you have all of this hemolyzed blood that was being reabsorbed into his body. And that was just the same thing as a hemolytic reaction. Okay. Biliary obstruction we've already talked about. Very good. Intrahepatic cell damage, hepatitis A, B, and C. Don't forget about mono, and don't forget about cytomegalovirus. If you have somebody that comes in, they're yellow, they're right upper quadrant pain, and you suspect hepatitis, get a hepatitis panel, A, B, and C, plus a CMV and a monospot, because it could be any of those. And of course, you know the other, you can easily figure out the other three. Jaundice, as the total bilirubin starts to rise, the jaundice begins from the head down. So when you get as little as 3 milligrams per deciliter, that's when you get icterus. And it takes a lot more to make it all the way down to your feet. The itchiness in the skin starts really low. So you see that. There's another thing you need to be aware of. You're going to cover it more in OBGYN, and that's newborn, jaundice of the newborn. Because they lack the ability to metabolize bilirubin, within a few hours to days after birth, they start turning yellow. And you're going to monitor the bilirubin levels for the first few days of life. They'll have icterus, they'll have jaundice. And as the bilirubin levels rise, and you know, if your bilirubin level was up around 15, you'd be in really, really bad shape. But here you have a newborn, just a day or so old, with a level that high, and they're not in bad shape. So what you have to do is, you have to do certain things to get it down, and you have to monitor it to make sure it doesn't go up any higher, because if it does, it produces a syndrome called kernicterus. And that is a hepatic encephalopathy related to elevated bilirubin levels. They can wind up with cerebral palsy, all sorts of nasty things related to that. One of the first things you want to do if you have an infant with bilirubin that's going up is you want to stop breastfeeding. Stop breastfeeding for the reasons you see here. Put them on formula for a few days. Formula doesn't interact with the bilirubin at all, so that's why you want to get them off of breast milk. And you want to put them under Billy lights. The bilirubin that's in the skin, you can deactivate it through ultraviolet lights. And so you put them under black lights for a day or 2 or 3, while you're monitoring the bilirubin level, and it comes down pretty quickly under Billy lights. They may have to stay under the lights for a few days. These are the lights over here. That's the light right there, not that. That's the incubator. They're the lights. And you can get these for, you don't have to do it in the hospital. You can do it at home. Shannon, do you have a Billy light for your kid?
We had to from my son.
How long were they under the light?
Like 3 days, and you had to be on it unless you were feeding them or changing them.
Yeah.
They could with their eye patch, but now they have Billy blankets. You
Oh.
wrap them and they literally light up, and so that protects their eyes because it can damage their retina.
Right. Yeah, we have to mention that. You gotta have those things.
That picture, both of my older ones had to be in the light, so they got their little glasses on.
And in case you were going to ask, this does not work in a person with a cirrhotic liver. It doesn't work, no, it doesn't work with adults. The Billy lights here, the Billy lights here. And more frequently than not, here you see 60% of kids have to be treated like this. But again, the first thing you should do while you're getting the Billy lights arranged is to tell mom, you're going to stop breastfeeding here for a few days. So we can, now you want to get her to start back. You know, once the child's metabolism can take care of it. And that happens just a few days into it. So you want to start back on breastfeeding, but you have to stop it temporarily. Now, enzymes associated with the liver, these are, as I mentioned earlier, you need to take another break. I see some restlessness here. Maybe because we're getting towards the end. Maybe that's what it is. Okay, keep going. Keep going. Okay. Again, not liver function. One is outphos. Think of outphos this way. It's highest in the cells that line the biliary tree. So when you have a duct stone, and now you have a dilated bile duct, the outphos will just soar. It goes way up. If you have biliary tract cancer, remember yesterday I was talking about cancer of the biliary system, this is where you're going to see it, right here, outphos. Anytime you have an elevated outphos, you need to get worried. Now the other place that you see outphos is in bone, so bony metastasis or a fracture. Outphos will actually be elevated in teenagers, late teenagers, because of growth spurts. And the way you determine if that elevated outphos is from the liver is you look at the other liver enzymes to see. Okay. Extrahepatic, you see it goes up quite a bit. Intrahepatic issues, not so much so. It's mostly the biliary tree where you'll find this. And as that bottom thing says, your first thought here is that there's an obstruction. Here's bone outcross. Paget's disease is another disease we'll talk about when we get to the musculoskeletal disorder. It's disordered bone growth, and because it's not well synchronized, outcross will elevate. GGT, gamma-glutamyl-transferase, is an enzyme that used to be really, really popular because if you drank alcohol, GGT would go up. And it was thought to be a pretty sensitive measure of alcoholism. If you know, Bethany comes in, and part of the history here is that she doesn't drink, get a GGT level on her, and sure enough, it's, you know, it's 5 times normal. Well, you do drink. But actually, we don't use GGT much anymore. You can use it to confirm elevated outphos, but there are other ways you can also tell if outphos is coming from the liver. I haven't ordered a GGT in probably 15 years. You guys? We used to order it on everybody.
No, you use Black Rock.
It's that ratio.
Black Rock, everybody's doing that. And Blackwell, when we were
No,
practicing.
no, I heard that. I was, because that's a war.
I think you do the ratio, AST to ALT ratio.
Yeah, I'll get to that here in a little bit. Okay? Here's GGT. We used to have, when I was in, over at OU, we used to have, we call it GGT rounds on Friday afternoon. We'd meet in my office and get drunk on Friday afternoon. So, we got away with that because people stopped, well, we got the police after us one day, so we had to stop that. We took it off campus. We continued to get drunk. That's why I have a teenager now. That's a whole other story. We'll move on. So Casey, you can sit there and shake your head like you're in disgust with me. I'll tell you what, 10 years from now, I'm gonna see you with 4 kids cramming along behind you, and you're gonna say, yeah, I remember that. You're a nasty little woman. So two primary enzymes for liver assessment. I'm not going to say function, liver assessment. One of them is AST. It used to be called the SGOT. We still say that, but I haven't seen that term in 20 years. So AST. The other one is ALT, alanine aminotransferase. Aspartate and alanine aminotransferase. They're not specific to the liver so much, but they're predominant in the liver. You confirm one is from the liver by the elevation of the other. This is, as I was doing this, formerly known as SGPT, I had to put that symbol in there. You know what that symbol is?
Prince.
Yeah, formerly, the artist formerly known as Prince. It was a stupid ass symbol. I mean, what a scrotum. Anyway. Although Showtime has a what?
I said breast and soul.
Well, Showtime has a whole documentary on Prince, and he was a talented guy. There's no doubt about that. He was talented. I mean, you know, you get enough alcohol in you, you start moving. You can't help it. But to come up with a symbol that, I mean, come on.
Wasn't his guitar shaped like that too?
What?
Wasn't that the shape of his guitar as well?
The name. It wasn't a name.
No, the guitar.
Yeah.
Was that shaped?
Well, he had a symbol everywhere, but I mean, there was no name. That was the whole point. He didn't want a name, right? It was an artist formerly known as that symbol. I mean, formerly known as Prince was that symbol. Okay, we got off track just a little bit. Okay. I heard that. I will tell you that ALT is more specific to the liver than AST, but you use both when you're looking at liver disease. So here are a couple of things you need to memorize here. And I say memorize because you need to memorize this for your board too, because you will have questions on your board exam where they give you an AST and an ALT and an alk phos, and they say, what's the problem? So, if AST elevates more than 10 times, you want to think viral hepatitis. The normal AST and the ALT is 0 to 30, probably milligrams per deciliter. So if you got an AST of 500, you need to be thinking about hepatitis. AST is less than 10 times, then you need to think about other things, not intrahepatic. The AST to ALT ratio is also very important. If it's greater than 1 or less than 1, that will point you in the direction of intra or extrahepatic. I'll bring this up again here in just a second. I want to conclude the enzymes with LDH. LDH it used to be used a lot for liver testing, but not so much anymore. Nobody even gets it anymore, but it's on a CMP, so that's why I'm bringing it up here. There are different isoenzymes, so it makes it difficult to tell where the elevation is coming from. That's why you want to focus your attention on AST, ALT, and alk phos. As I said, there are isoenzymes. It used to be, when you, in cardiology, did they talk about cardiac enzymes, LDH being one of them? It's still on a lot of cardiac panels, but it's really not used that much. Now, like with cardiology, you're focused on troponin and CKMB, and here you're focused on the other enzymes. PT is an important thing you always get in the face of liver disease. So if you have hepatitis, if you diagnose hepatitis, I would go ahead and get a coag panel. You can get a specific PT-INR or a coag panel, whichever one's cheaper. Probably the coag panel is cheaper to get.
And that's a better judge of liver function.
Yes. This determines liver function. Albumin determines liver function. PT determines liver function for obvious reasons. Okay, right? This is another one. The liver converts ammonia to urea. So when you're looking at, and urea is what, the blood urea nitrogen, that's what your kidneys expel.
That's what H. pylori, maybe that's what we give them, breast urea. I wonder if it's ammonia.
I don't think it is. I don't think it is.
I'm gonna Google that.
Breathing in ammonia is deadly. That's why I'm thinking it's probably not, right? You know those rail cars carrying ammonia, they fall in and everybody in the town dies? So I would say, here, breathe this. Anyway, a person with serious hepatic disease, like we've seen in earlier slides, the ammonia level will rise. The reason people have confusion, coma, mental status changes in cirrhosis is because of an elevating ammonia level. These people have to be dialyzed to get that down. Otherwise, they'll go completely nuts. So,
It's a level that you check as well before you do the paracentesis. If you've got a huge belly like that, you better be checking their albumin level and their ammonia level before you begin, because of the protocol for predicting that.
yeah.
They may need something else before you do the paracentesis.
When we get to the kidneys, which is, I think, the next section, we're going to talk about urea a lot more in terms of renal function. So right now, it's ammonia that we're interested in. Calcium is another issue when it comes to liver disease because, and I've explained it here. Okay, so when I get a serum calcium, normal range of serum calcium is going to vary lab to lab, but it's around 9.5 to 10.5, or 9 to 11, something like that. That's the normal calcium level. Normal level, the total calcium level you get, half of it is made up of bound calcium to albumin as a carrier protein, and it's not active physiologically. The other half of the albumin, which would be, let's say, 5 and 5 each, 5 milligrams per deciliter each, would make up 10, right? Everybody following? So the 5 that's not bound, that's physiologically active. Bailey, you follow me there?
No, I'm a little confused.
Okay, all right. So I get a serum calcium, so I get a calcium level, which is on a CMP, right? Which is on a CMP. The normal range, we'll say, is 9 to 11. So when you absorb calcium from the gut, as a result of vitamin D, renal influences, parathyroid, calcitonin, all that kind of stuff, all that plays a role in calcium levels. Half of that level is bound to albumin. So 5 milligrams per deciliter is bound to albumin. If something is bound to albumin, whether it be a thyroid hormone, your T3, T4, or this, it's inactive. Testosterone, if it's bound to something, it's a carrier protein, it makes it physiologically inactive. What is physiologically active is the unbound segment. This is the physiologic level here. Now, calcium, is involved in cardiac muscle, is involved in muscle contraction, right? So whenever the calcium level gets outside of that normal range, tissues that rely on calcium, specifically your heart muscle and your skeletal muscles, they don't like it. Tetany, Dipstick sign. Have we had that in class lesson yet? Hypo and hypercalcemia. We'll cover it later on. Probably when we do renal. Yeah. Hypo and hypercalcemia, you have to pay attention to. Hypercalcemia will shorten the PR interval, or the QT interval. QT interval. What is PR interval? No, QT interval. Hypocalcemia elongates it. Okay, so that you can have an effect on the heart. So hypercalcemia is a bad thing. You don't like it. The panic level of calcium is when it gets less than 7 or more than 13. Then you should start to panic. You're going to see cardiac effects when the levels get below or above that. You don't want them to get near that. Okay? Let's say I have cirrhosis. The normal level of albumin in your blood is 0 to 4. So we're going to say 4 is my reference point. Remember that albumin is binding to calcium here. If I have an albumin level of 0, and I've seen it I don't know how many times in people with cirrhosis, what does that do to this? That means if I get a calcium level, let's say the calcium level is 10, well, 0 of it is this. That means all 10 is unbound. That means all 10 is physiologically active. So if I come back over here to the panic level, right here, and you have normal albumin, that 13, that's 6.5, and 6.5 bound and unbound. So 6.5 unbound will kill you. You're now at 10. So the way you deal with this is when you have a patient with cirrhosis, you look at the calcium level and you look at the albumin level. When you have a patient with renal failure, you do the same thing, because their calcium is going to be jacked up too. For every 1 gram decrease in albumin, you have to increase the calcium level by 0.08. Actually, that's wrong. It's calcium level by 0.8, not 0.08. 0.8. So, in our case here, let's say we've got a guy, I get a calcium level, let's say his calcium level is 10.2. Okay? Calcium level is 10.2. Is in the normal range. I won't even get a little asterisk on the CMP. But his albumin is 0. So I'm going to say 4 times 0.8 is 3.2. What I do is add that to this. So, numerically, his calcium is 10.2. Physiologically, his body is going to act like it's 13.2. Okay? And that's what that formula says. Right? So, every patient you see in Good Shepherd with liver disease, hepatitis, or renal disease, I want you calculating that, okay? Now, here's the thing about the pattern of the liver enzyme. I should have put this table after the discussion on ALT and AST. This is the thing to memorize right here. This will get you points. This will get you correct answers on your national board. There are only 2 things. When I walked in and take the national board, there are only 2 things I studied. I remember I walked in there cold, there are only 2 things I looked at. One of them was this, and one of them was the chart that says where all the heart murmurs. You know that thing that Lovelace did the other day? He was upstairs, he came upstairs and was showing me that. I've never seen that before. He's exactly right. So now, this is the only thing you have to study. So, because there will be questions on, is it hepatitis, is it pancreatic cancer, is it obstruction, is it whatever, okay? And that's all I know about the GI tract. Any questions? All right. See you guys. Yes, ma'am.
Did you get that 4 times 0.08? I'm sorry, what do you call that?
The 4 would be the 4 grams, the 4 grams of albumin.
So his locks at 4 not 0.
Well, no, if his CMP says albumin level is 0, then I'm using 4 as the reference point. So if his CMP came back and said his albumin level was 2, I would say 2 times 0.08 is 1.6, and that's what I would have added to this over here. It still would have been in the same range. Okay? I'll see you fine folks later on.
I think it's at 8. I don't know. Oh, don't share. Sorry.
Crazy.
Sad.
The end of this is already out.
Nope, it's